Hello and welcome to this Allergy UK patient webinar on understanding and managing anaphylaxis. My name's Holly Shaw and I'm your host for this webinar. I work as a clinical nurse specialist for the patient organisation Allergy UK. This anaphylaxis webinar is going to be a wonderful opportunity for those that have an interest in learning more about anaphylaxis. Whatever sparked your interest in joining this webinar, I hope that by the end of the session you'll feel more confident and better understand how to recognise and treat the symptoms of a severe allergic reaction. We're delighted to have some clinical experts in the field joining us to present these sessions this evening. Professor Georges Dutoit is a paediatric consultant looking after children with allergy. He has a wealth of knowledge and expertise to share with you, and he's going to walk you through understanding what anaphylaxis is. Following his understanding and introduction to that, we're going to move on to a more practical based session where we're going to understand how anaphylaxis is managed and treated, and that session is going to be carried out by nurse specialist Alia Boardman. During the session there'll be plenty of opportunity should questions arise for you to post those on our Q&A platform Slido, and we'll cover the details on those later on in the presentation. So Allergy UK is a patient charity. We've been around for a while. It's our 34th year. We are the leading patient organisation supporting people living with all types of allergy, and that's both IgE and non-IgE allergies. Our mission is that nobody should die of allergy, and our vision is that everyone in the UK takes allergy seriously. And through the work that we do, we aim to empower, educate, contribute to research and influence stakeholders and organisations that can make a difference. Allergy UK has lots of work to do. Millions of people worldwide are affected by allergy. You may have a personal interest because yourself or a family member lives with one or more types of allergy conditions. We know that there's a big allergy community out there that really needs our help, advice and support in living with the challenges that allergy bestows upon us. And we have lots of work to do with raising awareness of allergy, both in the general community and as well amongst healthcare professionals. We offer a wealth of services, information and support in the work that we do at Allergy UK. And one of the patient-facing platforms is our helpline, which is staffed by our trained and specialist advisors who support patients calling in with different aspects and different questions that they want advice and guidance on, and they're supported by a clinical team and our health advisory board, so a collection of experts in the field that can help answer your response and query and support your needs. Our helpline is super busy, and the helpline staff Monday to Friday 9 till 5. Some of the clinical services we offer at Allergy UK include specialist dietetic support through our dietitian service, and also specialist skin and eczema support through our eczema clinic appointments. And this year marked a special occasion for our dietitian service appointment, supporting over 2,500 families to date and being in its 10th year of service this year. Not only do patients contact us through our website, but we also engage with people through other platforms like social media. We have lots of fact sheets on our website that cover a breadth of allergy subjects, and these are really useful because they provide more in-depth knowledge and specific information. We hold webinars on the website across lots of different areas of interest in the allergy spectrum, covering food allergy, respiratory allergy, skin allergy, drug allergy. So there's lots of information. I encourage you all to explore our website for what's available. We also support healthcare professionals because not all are as familiar with allergies as others. So we have a big role to play in educating healthcare professionals in the work that they do to better support the needs of those living with allergy. And we work with lots of stakeholder partners as well to deliver and lead on our strategy and our vision. And these are just some of those that we work with closely. During the webinar, we will invite you to post any questions you have using the question and answer polling platform Slido. It's really easy to use. If you just go to slido.com and you put in the code hashtag AUK11December, you'll be able to post your questions, and these will be looked at and addressed within the time frame at the end of our webinar. We're going to be joined by our panel of speakers, and we'll do our best to answer as many of those questions as possible. So without further delay, I'd like to thank you for joining us, and I'd like to hand over to Professor Georges Dutoit for his presentation on better understanding anaphylaxis. Thank you, George.
So welcome everyone to this Allergy UK patient webinar, Understanding and Managing Anaphylaxis. So my name is George Dutoit. I'm Professor of Pediatric Allergy at the Evelina Children's Hospital and at the Allergy Centre of Excellence in Marylebone. So I'm very pleased to be able to chat about this topic this evening, and hopefully you find it of interest, and we do have Q's and A's afterwards, which we will take live. I'll be presenting alongside Alia Boardman, who is my expert specialist allergy nurse. She'll be presenting after me. So the aims of my section is to briefly go over the definitions and the understanding of anaphylaxis. Easier said than done. I'll point out some clinical features, trying to be as practical and patient-orientated as possible with some key lessons. I have 2 simple case studies and perhaps some takeaway key messages. So what is anaphylaxis? So anaphylaxis is a syndrome. A syndrome is where you put lots of symptoms and signs together. So anaphylaxis is a severe, potentially life-threatening, systemic, that means the whole body is involved, hypersensitivity reaction. What does that mean? Well, it's characterized by rapid onset. So you can have delayed anaphylaxis after exposure, but usually it's soon after exposure. And we worry about airway, breathing, or circulatory involvement. It is usually, but not always, associated with skin and mucosal changes. So hives and rashes and a swollen lip and swollen eyelids. And importantly, it requires immediate medical attention, and adrenaline remains the drug of choice. So that's a whole lot of words. What does that mean? How do I train my patients to recognize this? Because obviously even severe reactions start with mild or moderate symptoms, but mild and moderate symptoms usually remain as mild and moderate symptoms. So anaphylaxis is actually quite rare in amongst all those positive reactions. So I train my patients that if symptoms on the outside of the body, so perhaps just a swollen lip or some hives and a rash that is not too severe, or some itchy eyes or some sneezing, then this is usually a milder variant of anaphylaxis, and perhaps an antihistamine will be fine, but always call for help in that immediate setting. But if symptoms on the inside of the body, so you have an altered voice, rapid breathing, a pale and floppy patient or child, then obviously things are more severe, and that's pretty intuitive. But in truth that's very rare. The milder wheezing is not easily elicited and perhaps may be missed, but the more severe symptoms will certainly not be missed. So what is the science? What happens inside the body? Well, you need to be sensitized. In other words, you need to have pre-existing antibodies to whatever allergen you're going to react. And so if you take peanut, for example, people often think the first time they've given peanut to the child, that made them allergic. In truth, it must have happened prior to that, because it'll take at least 10 days or so to make antibodies to peanut. But you can, as you see in this little figure, you can make specific antibodies, usually through exposure that occurs via the skin and not the mouth, but it can be through the mouth as well. And then to have a reaction, you need exposure. So you need to absorb this allergen, this peanut, into your bloodstream. Then it needs to be exposed to these cells. So this is in the tissue compartment. So the eyes, the esophagus, the skin, the gut. And then you get a release of mediators, and that's what you'll see and feel. So that feeling of impending doom, the redness, the hives, the swelling, that is all due to the release of those mediators, and that's called an allergic reaction. So that a rather hectic introductory slide. Let's break it down. Symptoms and signs. So we have an adult patient here, and this can vary between adults and children. So adults are more likely to get cardiovascular embarrassment, in other words, a blood pressure that drops, and children more likely to get into harm from respiratory embarrassment. So wheezing and coughing and a tight voice. But of course, this can vary between amongst all ages. So just starting on the top left, looking at neurological signs. So these are quite common. Children may suddenly become anxious before you even see signs of a reaction, or they may become clingy. They may stop looking at their iPhone, which is a miracle in itself, and seek out parental care or comfort. And adults can also feel this feeling of impending doom. Something is not right. Looking at nasal symptoms, it's not uncommon for the nose to suddenly start running, to be itching, to sneezing, an incredible force of sneezing and recurrent sneezing. You may notice that as your nasal symptoms. Cardiovascular is a little bit more difficult in the everyday setting. Your heart may go fast, blood pressure may drop, so patients may be a bit floppy, limp, unresponsive, gray. And of course, if you can measure it, which is not easy in children because they don't like the BP cuffs, it may have reduced a bit. Arrhythmias, uncommon, and cardiac arrest, please, exceptionally uncommon. So skin and mucosa, so this is often involved. You'll see people feel a sensation of warmth. You'll see some hives, some flushing, generalized redness sometimes, itching, and swelling of the eyelids and of the lips of the mucosal membranes. And that's very frightening. So people worry that's happening on the inside of the body. Ocular, so if you look at the eye signs, the eyes can itch and they can water. We call it injected. They go bright red, as would occur with hay fever. And of course, looking at the eyes, it's a tip for you. If you've given adrenaline and perhaps the child's moved quickly or you're not sure you've administered it properly, the pupils should dilate, like the old belladonna eye drops. You should have pupillary dilation after adrenaline administration. Upper airway signs will be a new onset cough. This is very common, a recurrent cough, and it doesn't always worry parents because everyone's got a cough, kids most of the time over the winter now. But if it's new onset and it's striking, of course, that'll worry you. And if the throat feels tight, or kids use different words to describe this. It feels gritty or spiky, or the food tastes metallic, the back of their throat feels strange, then of course you're worried about upper airway signs. Lower airway signs can be breathing fast, breathing with force. A patient sits up, they use their accessory muscles, they become hyperinflated, and wheeze or a wheezy cough. That is more obvious when it's severe, but often there's a subtle wheeze that we pick up and parents haven't noted. And then gut symptoms, obviously nausea, vomiting, new onset vomiting. Sometimes this can be recurrent and striking vomiting. Cramping, you can get very severe abdominal pain and diarrhea. And of course, in older females, uterine cramps can also occur with this. And adrenaline works for all these symptoms when severe. The drug of choice. So let's take it to the extreme, fatalities from anaphylaxis. Thankfully, this is exceptionally rare. What you're seeing is not the tip of the iceberg, but the entire iceberg. Fatalities are rare, but they occur. So we all live in fear of an extremely rare but catastrophic event. And what we see is quite mysterious. So on the y-axis, we're looking at fatalities per 100,000 population, and this was in the UK. On the x-axis, we're looking at age. So remember, children carry the brunt of food allergy because they still have milk and egg allergy, which is usually outgrown, and their other allergies develop often within the first year of life. But the fatalities are very low in the first 4 years. You're seeing none or very, very few, thank goodness, in the first 4 years of life. So although that's the most worrying time because you're the parent, you're nurturing your allergic child, and you're wanting to expand the diet for allergy prevention, you're also worried that you're going to cause reactions and severe reactions. And I reassure patients that the risk of death throughout their child's life is exceptionally low, but particularly in the first years of life, it is very low. And then strangely, it goes up, and I'll discuss reasons why. Some physiological, some behavioral, some your mom and dad are not around to make sure you're eating safe foods. And then, so that's food, if you're looking at that pale blue line. And then iatrogenic, which means, or probable iatrogenic, so that's either medicines or it's occurred in hospital. And sometimes we're just not sure. That goes up with age. But obviously, the amount of medicines we take and hospitalizations go up with age. Insect stings cause very few fatalities and very little anaphylaxis in the UK. Our bees are very placid. Wasps seem to cause more trouble on the continent. Bees would cause more trouble, but very seldomly severe anaphylaxis, and fatality is very rare. But of course, that can occur in younger kids, slightly less common. So if we look at Shelley Dew's wonderful data, they did the study looking at threshold doses. So a threshold dose is a dose at which you will have a reaction, and this was to peanut. And this was in older teenagers and adults. And you can see that there are many things that alter the risk you carry for a severe reaction. So on the right-hand side, you see a baseline where there was nothing added other than the food, and then sleep deprivation and exercise. You can see how this curve shifts. So you react to a lower dose of allergen, as you can see on the x-axis, if you're sleep deprived or if you've done exercise. And the same thing can happen with menstrual cycles, ibuprofen, alcohol, extreme excitement. So your immune system is very plastic and variable. I'm probably starting off, I never realized how much this is, but we have children on oral immunotherapy on set doses of allergen, and you can still randomly have reactions when one or more of these cofactors are present. So the purpose of this slide is just to show you that your immune system is not static. You can't always predict how you're going to react in the future. You may react more severely than the last time or less severely than the last time. There are just so many variables: how old you are, what the food is, what the matrix is it baked? Did you eat a lot of it? Did you eat a little? Are you sleep deprived? Have you been sick, as in with a viral illness? All these things can affect, and so you get these multiplier effects. So let's look at the green multipliers. So of course, if there's a complex matrix, the food is taken with alcohol. For those of you who've taken alcohol, you will know if you have a glass of champagne, it rapidly, that bubbly sensation that you feel just shows how the alcohol can facilitate the uptake of substance through the gut mucosa. And of course, if there's peanut and you're allergic in that meal, that sets you off quicker. Looking at the next risk factor, your IgEs and your skin, by inference, your skin prick test size. So we don't like to say that size predicts for severity. There is some data that does speak to this. Certainly within our LEAP study with Alex Santos, we have published in this regard. But by and large, you can have a severe reaction with a small test or with a large test. It doesn't always predict for severity because there are so many other variables. If you have a large allergic burden, such as concomitant asthma, rhinitis, eczema, or an overgrowth, if you want, of mast cells, mastocytosis, you're obviously at more risk. If you've done exercise, sleep deprived, if it is extremely hot, if you have an illness, age, you can see makes a big difference. Young babies being protected, alcohol, and then certain enzymes and medicines. If you've taken these, you're slightly at more risk. Aspirin, which children don't take, but they vaguely related to non-steroidals like ibuprofen. This can facilitate the uptake of food. And then your amount of adrenaline administration training will also contribute to how severe a reaction can be. So looking at other allergic factors, let's start with atopic dermatitis on the right-hand side, the purple. So most of the allergic patients I see have eczema or had eczema. But if this is extremely active and extremely, the distribution is wide on their body, then you are at a greater risk of hypertension with nut anaphylaxis. If you look at asthma in the middle, some 60 to 90% of allergy deaths, of which there thankfully are very few, occur in people who have asthma or who had asthma in the past. So if your chest is unstable and you then eat your allergen, you're already on the back foot. It is very hard to deal with this physiologically. So nut allergy and severe asthma is a 6.8 times risk of life-threatening bronchospasm compared to mild asthma. So that's why we spend so much time in our clinics stressing the need for good asthma control. And the same is largely true, although it's less dramatic for rhinitis. But remember, your nose and lungs are all linked. So if you've got bad asthma, you very likely will have rhinitis. And if you've got rhinitis, it's been demonstrated that you will have some lower airway hyperreactivity. So what about teenagers and young adults that seem to be at such risk? Why is this? Well, some is behavioral, the sort of invincible, not me, but most of the teenagers I'm seeing are certainly not being too gung-ho about this. Alcohol, will some drink, some don't. Drinking responsibly will be fine, but if you're on immunotherapy, it can be a cofactor. And if you drink a lot, obviously your behavior can be altered, and perhaps you'll eat nuts that you wouldn't have otherwise. I don't often encounter that in clinic. Teenagers just don't carry, or many of them, their auto-injectors or now the Anaphylaxis, the nasal device that we have. So that's a real lost opportunity. About 40% of scripts are filled and carried, and of those that carry them, very few actually use them when they should. So there's a great missed opportunity and miseducation on our part, on society's part, and on the individual's part to carry their devices. You can only use the device if you have it on you. And anaphylaxis and catastrophic anaphylaxis occurs within a very short period of time, and a lack of control, recognition of other allergies. So I believe teenagers physiologically are also just at much greater risk. So what should your emergency response be? So Ali is going to speak to this after me, but for severe reactions, you need adrenaline. And so we've been focusing on the AAI devices, and there are two that are in the UK at the moment. We have EpiPen and Jext, 0.15, 0.3, sorry, is a type error there, the 0.3 milligram dose. 0.15 ideal when you're 15 kilos, 0.3 ideal when you're 30 kilos. Many of our patients are 50, 60, 70, 80 in adulthood, and so there just isn't a bigger dose at the moment unless you draw this up with needle and syringe, which people are only doing in medical settings. So it's important to carry two because you may need two devices and you may botch the administration of the first dose. Although it seems very simple, it's called a pen, so people often turn it upside down and click and inject themselves, or the child moves and you don't get the dose in. Worse still, they lacerate their thigh because of the needle. And also people are just scared of injectable devices. Parents aren't familiar with it mostly. Certainly the children don't encourage it. So it's hard to give these. Thankfully, the field is now moving. So we now have in the UK the Anaphylaxis license at 2 milligrams. This covers a weight of 30 kilograms or more. So that's about 9 or 10 years of age. So your GPs in the NHS should be able to access this in 2 or 3 or 4 months. It's just taking some time to come through the NHS system. In America, there is a lower dose, 1 milligram, approved by the FDA, and that's for 15 kilos and above. So it shouldn't be too long, hopefully, if the MHRA approve this, that a lower dose will be available for younger children. And certainly it's my hope that this will facilitate carriage. It's more temperature stable. They're much smaller to carry, so for teenagers, it's particularly handy. And also there's no needle, so hopefully people will use this sooner. Call 999. So communication is essential during anaphylaxis. People must know who you are, what's happening, where you are, and you need appropriate care. And so we spend a lot of time training people to say anaphylaxis. That will normally get you a rapid response if that is even possible. And positioning is important. In children, it's very hard because they fractures during a reaction often are picked up and comforted. But in people who are slightly older, if their respiratory system is stable, they should lie down in a comfortable position, in a supine position, and not be moved soon after anaphylaxis. Otherwise, you can induce an empty ventricle, and this is certainly thought, long-standing data from Richard Pumphrey, that this may go on to more catastrophic events. So do not let them stand or walk, even to get to the ambulance. They should be carried to the ambulance. And then just to remind you that the updated Resus Council guidelines emphasize repeated intramuscular adrenaline as the first line intervention. So adrenaline and then more adrenaline. Doses repeated every 5 minutes. Corticosteroids, so many of you will have experience where a doctor gives you corticosteroids. They're fine if you've got asthma and you're going to wheeze hours later, but they take hours to work. They will not help in the acute setting. They may actually counter the good effects of adrenaline. And the same is true of antihistamines. For anaphylaxis, a severe allergic reaction, antihistamines do not play a role and are not even in these guidelines, although they're still commonly given either injectable or by mouth. Of course, if your symptoms are mild and your child is uncomfortable and scratching, an antihistamine will provide some relief. And people prefer to give a syrup as opposed to an injection, so I can see why they are commonly given. But these are no longer in the MHRA guidelines, updated Resus Council guidelines. So there is some new news. Having said that, every severe reaction I attend, when the response team arrives, they always try and give these drugs. So it's a very hard message to get across. So what does adrenaline do, this magical drug? So adrenaline is a very basic drug. It's very cheap. It's been around forever. It's a World Health Organization basic drug. So every child, human, should have access to this throughout the world. That's sadly not the case. Very few people have access to auto-injectors, and even fewer have access to the nasal adrenaline device. There are other mechanisms for administration that have been studied, that have been submitted to the FDA in America, such as a sublingual mist or strip, where you would absorb this, but those are not licensed. The point why I'm mentioning this is the field is moving forward, and that is very exciting for all of us. So adrenaline is just like this fuel. It helps your heart beat stronger and faster. It helps your airways to open up nicely. It has some metabolic favorable consequences. It reduces mucosal edema, so that swelling you see, if there is any mucosal swelling within the body, it helps reduce that. But what is very exciting for me is this beta-2 receptor. So these are receptors on cells. And if you stimulate that with adrenaline, you may inhibit mediator release. And what I'm hoping that with proper training of auto-injector use, or with earlier use of nasal adrenaline, we may optimize this effect of mediator release. So if we intervene earlier in this cascade, perhaps outcomes will be more favorable. So here are two case studies that hopefully will be intuitive. You can already see the key learning, but try not to read ahead. So this is Leo, age 7, a diagnosis of mild cow's milk allergies in infants. Parents were told to avoid milk, but haven't seen a severe reaction. So this is not uncommon. Well, it's uncommon that milk allergy isn't outgrown by age 7, but in those who have retained a milk allergy to age 7, it can be a more troublesome variant. And in fact, milk allergy is associated with more catastrophic allergy outcomes than what is peanut, particularly in teenagers, a very nasty allergen. And it's ubiquitous, very hard to avoid. It's called different things, so children can easily make mistakes and ingest it. So this is a family who have fastidiously avoided the cow's milk, and good on them for doing so. But you then are in a zone where you just really don't know, has this been outgrown? Is this severe? So they obviously haven't had testing. They just continue with avoidance. So then at a birthday party, Leo ate a sorbet labeled dairy-free, which was cross-contaminated with milk protein. He complained of an itchy tongue and then developed a persistent cough and became very quiet and floppy. So here you see this cascade nicely detailed. So a child will say, at 7 years of age, I'll complain to somebody saying something doesn't feel right in my mouth. It feels very itchy. And of course, you'll think this will settle. I'll just give some antihistamine. Let's all calm down. Well, that usually will settle, particularly if they've got a milder variant. But this didn't. And then you develop a persistent cough. So often you'll think as a parent, well, perhaps they've choked or they haven't swallowed properly. But if this cough is ongoing, if the voice is hoarse, if the child looks scared, often you will have a deep-seated innate worry yourself. You will know this is not right. And then certainly if they went very quiet and floppy, that would indicate that neurologically things are not great. So either this is hypotension with altered behavior, or there are other mechanisms where children go quiet and floppy. And in younger children, we've put this forward as a phenomenon known as plain possum, where many species will literally switch off to avoid exposure to the allergen. But this is catastrophic, and this is anaphylaxis, and you need to treat this. So the learning is, don't underestimate mild history. So what was mild can become severe. What was mild may stay mild. What was mild may go away. So you can't just leave a child for many years with, particularly for something like milk allergy. You need to investigate that a bit further along the way. Persistent cough and behavioral changes, in other words, quietness, are key signs of anaphylaxis. And as a parent, it's very hard to acknowledge that this is a problem. It's a bit like when you're crossing the road and you think you've seen a car and it's close, but you actually don't want to look at it in case it is there. It's that phenomena where this may be catastrophic and it's happening in a split second. And sometimes it's very hard to acknowledge, because if you acknowledge this, well, you're going to disturb this whole child's party. You're going to have to call an ambulance. It's going to make a big scene. Your child's probably going to get a bit upset with that as well. It's not an easy thing to acknowledge this is anaphylaxis, but it has to be done. The analogy I give is if your 7-year-old or younger yet ran into traffic, you would just pull them out. And so you need to act with confidence and certainty. And cow's milk allergy can persist into the teenage years. Thankfully, it does not always. More commonly now in children, we start introducing milk very early on to try and expedite and increase the chance that you outgrow this milk allergy. So let's look at a teenager. This was Maya, age 15. So Maya loved wheat, and kids can eat a lot of wheat. You can have Weetabix for breakfast, bread for lunch, pasta for dinner. You can eat heaps of wheat in our modern day diet. And she did this without issues. And she has mild hay fever. And then the perfect storm happened. So just after her lunch at midday, she had a nice big pasta lunch with wheat. She ran a cross-country race for PE at school. And then she developed an allergic reaction. So this is not common, but I've included this just to teach about variants of anaphylaxis. So this is what we call food dependent. It's dependent on wheat, exercise-induced anaphylaxis. So it's a very strange phenomena that you can exercise without any allergic reactions. You can eat wheat without any allergic reactions, but you put these two together and you expedite and facilitate the uptake of wheat, and then you do have an allergic reaction. So wheat, like milk in older children, is very hard to avoid. We do lots of immunotherapy, oral ORT to wheat now, and it's a tricky allergen. It is very sensitive to heat processing. So a soft pasta noodle behaves very differently to the crust of bread, where the wheat has been baked, and that Maillard reaction, the marriage of a protein and carbohydrate, has altered the structure of the allergen. So key takeaways: a medical emergency, recognize the signs early. This is hard to do, and you would have been given many sheets. That's why you're all members of Allergy UK. You would have had lots of information about how to recognize allergic reactions. What is mild is easy to recognize as mild, and thankfully will usually stay as mild in that setting. The next exposure may not start in the same way, but just a few hives or some redness or one vomit without too much distress. Often I see children or see pictures of children reacting and they look quite happy in that setting. That is obviously mild and hopefully and thankfully mostly what people will see. Moderate and severe become a bit more tricky. Like I said, if the wheezing is subtle, if the other symptoms are a bit subtle, then it is hard to know if this is still mild or moderate. For moderate, you want adrenaline. Obviously, for severe, you want adrenaline. For severe, well, extreme presentations are very easy to treat. Often the older child will ask for adrenaline, which is unique, particularly if it's an injectable device. The wheezing, they'll feel very distressed, and often they tell me their chest felt tight, like an elephant was sitting on it. It just felt heavy and hard to breathe. And the floppiness, we see floppiness in younger infants a lot. As children get older, I haven't witnessed, I've given a lot of adrenaline. I've not witnessed too much floppiness, but of course, if your blood pressure drops low enough, this can occur. And cough, like I said, you can have very mild, everyone's coughing, and you can have very mild cough, and it doesn't always bother parents. But new onset cough, a wheezy cough, and if it's starting to look distressing, then of course that speaks to severe allergic reaction, which is anaphylaxis. Triggers can vary with age. So milk and egg throughout the world are your commonest first food allergens. Then depending on where you live, there can be sesame, peanut, cashew, finfish, shellfish, The soys are more rare, the finfish are more rare, the shellfish are more rare, certainly in the UK, but they can all occur. What they have in common, most of them, is they are highly proteinaceous. They have a lot of protein in them, and it's usually the protein you become allergic to. It's very rare to become allergic to a carbohydrate. So when people react to fruits, it's usually a contact reaction, or there are some allergens within fruit you can have more severe reactions to, but it's usually a pollen cross-reactivity as opposed to a very severe primary reactivity. And then your milk and egg will fall off at a population level as you get older, hopefully, otherwise they're really troublesome. And the same is true for wheat. And then your nuts and sesame. Sesame is like a nut, it's just the seed of a plant. Those usually stick around, and the chance of outgrowing them is far less, 10-15%. Adrenaline is the only treatment for severe allergic reactions. People often play for time giving antihistamines or salbutamol inhalers, and I can see why people are scared of the auto-injector. Thankfully, we now have this Anaphylaxis coming onto the market, and hopefully in time there'll be yet more products where we don't always have to rely on the needled device. So antihistamines do not treat anaphylaxis. And try never use sedating first-generation antihistamines, because you then have a child who's had a reaction who's a bit groggy. And I've seen that just this morning in clinic, where a large dose of intramuscular antihistamine was given to a child, and then the child was absolutely asleep. And that can be very frightening for all of us, including us clinicians. Carry 2 devices. So if you've got the Anaphylaxis, you need 2 devices. Alia will teach you that a repeat dose is in the same nostril. For the intramuscular auto-injector, the repeat dose must be in the opposite thigh. So there's a slight conflict there. They're very hard things for teenagers to carry. They're large, they're long, the auto-injectors are. They're temperature sensitive, they expire frequently. So this is a real hassle. And hence, when you look at the amount of people that actually carry them and actually use them when they should, it is far too low. And this is a missed opportunity by all of us. The Anaphylaxis is very new on the market. I've had 3 patients use it during anaphylaxis, and it worked. And 2 of them were able to administer this to themselves, and in one, a parent gave it. You can get an adverse sensation inside your nose. Obviously, it's adrenaline squirted inside your nose. So these will be available on the NHS, and it'll be very interesting to see if that improves outcomes for us. And I'm hoping, once again, that they will be used earlier during allergic reactions and not delayed, because you just don't want to inject your child or yourself. I'd also spoken to a position being important. In younger kids, obviously, it's hard to keep them still and flat, but in older patients, try and let them rest, elevate their legs. That can return up to a liter and a half of blood to the heart, and your heart is just this massively strong pump, and it needs a preload and an afterload. So thank you very much for listening. Next up will be Alia, and then we'll take some live questions in a little bit.
Hello, everyone. My name is Alia Boardman. I am a clinical nurse specialist in pediatric allergy, and today we're going to be looking at how anaphylaxis is treated, stroke managed. By the end of this session, what I'm hoping is that you will know what adrenaline is, how it works, the devices that are available, and as well as demonstrations and practical tips of living with a severe allergy. Just a quick recap on recognizing anaphylaxis. So if you notice that a person's becoming pale, blue, drowsy, unconscious, coughing, wheezing, difficulty breathing, difficulty swallowing, perhaps you may note that they have a hoarse voice or cry, or the tongue is swollen, that's when you need to act quickly. Now, adrenaline, also known as epinephrine in other countries, is the first-line treatment of anaphylaxis. Remember, quick. If we are quick to give it, it is quick to reverse the symptoms of anaphylaxis. It is a very safe drug. It's a hormone that is naturally found in our bodies. It's released by the adrenal glands, and it's the most effective drug in treating anaphylaxis. What we need to remember is that it is a prescription-only medication, so you will not be able to buy it over the counter as you may be with antihistamines. So why do we need to use adrenaline? We have heard about what happens during anaphylaxis. Your blood vessels dilate, and that's what causes the low blood pressure, dizziness, unconsciousness. Your airways tighten and swell, and that is what causes the difficulty in breathing or the wheeze that might be noticed. So adrenaline acts quickly, and it works by constricting these blood vessels. It relaxes the smooth muscles in the lungs, and that's what improves the breathing. It stimulates the heartbeat as well, and it helps stop mucosal angioedema. Now, in the UK, there are 3 types of adrenaline devices that are currently available. We have EpiPen, Jext, and the newest kid on the block is Neffy. I'll start off with EpiPen. It has a spring-loaded concealed needle. This needle you will not see either at the start or at the end. It is available in 2 doses, 0.3 milligrams and 0.15 milligrams. The 0.3 milligram dose is also known as the adult EpiPen, and it is used for those who are 25 kilos and above. The 0.15 milligram or the junior EpiPen, 7.5 kilos to 25 kilos. With an EpiPen, you are able to get a free trainer pen. And also there is the expiry alert service, which we encourage everyone to go for. And they send you an alert 2 weeks before, a week before, and then the day after expiry of your device. With regards to shelf life, it is 24 months for the adult device and 19 months for the junior EpiPen. We then come on to Jext. Jext also has a concealed needle, and it comes in 2 doses as well. We have the 0.3 milligrams adult dose or the 0.15, which is a junior one. The 0.3 milligrams is for those aged 30 kilos or more, and the 0.15 is from 15 to 30 kilos. Now with Jext, you also have a free downloadable app. It also gives you the opportunity to obtain a free trainer pen, as well as the expiry alert service. I'm going to talk about the Jext app because a lot of young people say that they do find it useful. It's good patient support. It's available on your iPhone or Android device. It has an emergency guide, so it goes through how to use it, and this is in audio and visual. It also has training videos with regards to how to use your Jext device. The expiry alert service is also available, so you get an alert 4 weeks before, 2 weeks before, and then the day after your expiration. It also gives you traveling resources in 24 languages, so phrase sheets. And it also has a screen lock, as shown in this picture on the slide, which you can customize. So what you're allergic to, your contact details, and where your emergency medications are kept. Last but not least, we've got Uronephy or Neffy. In the UK, there is only 1 dose that is currently available, and that is 2 milligrams. And this is for people who are 30 kilograms or over. The great thing about this is that it is needle-free. It's a single dose nasal spray. So, you should have 2 of these. And it delivers its entire contents upon activation. So it's a spray up the nostril. And once again, you also have free trainer devices available for this. Advantages of Neffy. The best thing about it is that it is needle-free. So that makes it less intimidating. And I suppose people will be more likely and open to use this if needed. It is very easy to use. It is a lot smaller as well, so it's very portable. It also has a longer shelf life, up to 30 months, and it is temperature stable, so it's not affected by extreme temperatures. I would like to add that all of these devices serve the same purpose. So they will treat anaphylaxis. The only difference is the dosage and the cost and the route of administration. Although Neffy is great, it's not suitable for everyone. And it is not suitable for those who have previously had anaphylaxis and needed more than 1 dose of adrenaline. It is also not suitable for those who have had previous severe anaphylaxis with hypertension, low blood pressure. And this is more common in those with allergy to insect venom. With Neffy, it is best to have a discussion with your medical provider to see if this is something that may be suitable for you or your child. Now, when you're having anaphylaxis, we always say have 2 devices with you. So why 2 devices? And we say 2 devices because this is what is recommended both by the MHRA and the BSACI. The reason for that is that perhaps in the rare instance, there might be a device malfunction. It may be that your device misfires. Perhaps it is not held in for long enough. For example, EpiPen's 3 seconds and Jext is 10 seconds. Or there may be user error, and we have heard about that. So it's important to have 2. You may also have a biphasic reaction, and this could be within minutes or after, a few hours after as well. Or there may be a delay with emergency services arriving. So remember, 1 device to start and the other to back up. Treatment of anaphylaxis is not just with adrenaline. Although adrenaline is the cornerstone and should be used first, you will also need to have secondary medications with you, which will be helpful. And by secondary medications, I mean antihistamines or inhalers. So antihistamines would be, for example, commonly you would have Piriton or cetirizine. And inhalers, if you are asthmatic, you will be prescribed salbutamol, so you would use that. I am now going to go into the demonstration of administering adrenaline with each one of these devices. For this, I've got this lovely tennis ball because I thought it might be less messy than an orange. And I am going to start off with the EpiPen. Now, with administration, what you are going to do is you are going to go for the midsection of your upper thigh. So, holding the EpiPen like this, you don't need to press on anything. So the best thing to do is just hold your EpiPen device like this. Pretend this is the midsection of your thigh, upper thigh. You take the blue cap off. So blue to the sky, orange to the thigh. Take the blue cap off. You're going to then hold on to the leg. And from a distance of about 10 centimeters, you press it into the leg and count slowly to 3. 1, 2, 3. You then take it out, call 999 and say anaphylaxis. While you're waiting for the ambulance, what you will do is if you haven't given antihistamines, you will give antihistamines. If the person's asthmatic, you will give up to 10 puffs of salbutamol. If after 5 minutes help hasn't arrived and the symptoms of anaphylaxis haven't resolved or they are returning, that's when you will give the second dose of the EpiPen in the same way in the other leg. So I'm going to do it again. Hold like this, blue to the sky, orange to the thigh. Take the blue cap off, hold on to the leg. In there, you hear a click, count to 3, take it out. So that was the EpiPen. We then go on to the Jext. This is the Jext device. Again, nothing to press to activate it. So you hold it like this. You take the cap off, hold on to the leg, push it against the thigh and push in till you hear the click. With the Jext, what you need to do is count slowly to 10. Once you've done that, you take it out and you massage the area for a count to 10. Again, you will not see a needle at all. It's all shielded. Call 999, say anaphylaxis, give the secondary medications, if applicable, salbutamol, And if after 5 minutes symptoms haven't resolved or they return again, that's when you will give the repeat Jext in the other leg with your second device. Finally, we come on to Neffy. This is what it looks like. And what you would do is hold it at the top with your forefingers, thumb at the bottom. You put it up the nose until your fingers reach your nostril. So it's kind of going up to about there. And you're going to go aim straight up towards the head. Once it's there, all you do is just, and that's activated. And do not sniff afterwards. Exactly the same thing that you would do with the EpiPen or the Jext device. You would call 999, say anaphylaxis, give antihistamine or salbutamol if applicable. And then if after 5 minutes, this is where it's different. If after 5 minutes symptoms haven't resolved or they return again, then you would give the second dose of Neffy with your second device, but in the same nostril. So with the EpiPen and the Jext, you go for the other leg. With the Neffy, you would go for the same nostril. Position is also very important when it comes to anaphylaxis. If you're conscious, you need to be lying flat with your legs raised. If you are finding it difficult to breathe or you're vomiting, then the person may be propped up briefly, but as soon as they're beginning to feel better again, you must lie them down. Avoid sudden changes in posture, and whatever you do, do not stand the person up, even if they are feeling better. Do not walk them somewhere else to provide emergency treatment, and do not let them run. If the person's unconscious, you may put them in a recovery position. This is just to make sure that, it prevents choking, airway clear in case of vomiting. Do not leave the person alone. Someone should always be with them. Even if the person is beginning to feel better, you must always make sure that they are taken to hospital following anaphylaxis. My recommendation is that call 999 and let them take you to hospital rather than you driving to the hospital. So why do we need to go to hospital? The reason for that is that with anaphylaxis, you can have a biphasic reaction. So it's like a second wave of reaction. And in hospital, they will monitor you for any symptoms. They will also monitor you and make sure that you are completely better before discharging you. Monitoring may be up to 4 to 6 hours. You may also be given additional medicinal support. Perhaps you need more antihistamines or fluids or more adrenaline or nebulizers. The key thing also is that when you are discharged from hospital, you will be provided with replacement adrenaline devices on discharge. So you should always have them with you. And in some cases, you may also be referred to an allergy specialist for further investigation and management. So a quick recap. We need to be very, very quick in recognizing and treating anaphylaxis. If in doubt, treat. You're not going to do any harm. As I've mentioned before, adrenaline is completely safe. So you won't do any harm by giving it when not needed. More harm may be done when it is not given when needed. Always call 999 and say anaphylaxis. Make note of the time and also give your secondary medications. The second device that you've got should be used after 5 minutes. If there is no improvement in symptoms. Do not forget position. We need to be lying flat, legs raised, sit up if difficulty in breathing, but lie back down when you are able to do so. Whatever you do, do not stand up, and you must go to hospital even if you're feeling better. We now come to storage of adrenaline devices. So everyone who has been prescribed adrenaline, what we recommend is that you have a little pack or a little clear box, whatever is easy for you to easily access. And you keep your adrenaline devices, your antihistamines, your inhalers, your spacers, everything in there in one place so that it's easily accessible. Now, coming on to EpiPen and Jext, keep them in their original container to protect it from light exposure. They need to be stored at temperatures below 25 degrees centigrade and away from direct sources of heat. These are not meant to be refrigerated or frozen. If you are outdoors in freezing conditions, for example, you're out skiing, then you can use body heat. So these can be placed inside your pocket and the body heat will keep them warm. Avoid the glove box in your car during summer because that can get very hot. In case of EpiPen, regularly check the window to see if the solution is clear and colorless, for example. And if your devices are discolored, the liquid in them, or contain particles, this is when they need to be replaced immediately. With Neffy, room temperature again, 20 to 25 degrees centigrade. This is not meant to be frozen. However, if it does freeze, it will not spray until thawed, and then it may be used. Storage of Uroneffy at high temperatures is allowed for a few days, up to 50 degrees. But remember, you want to keep it at room temperature. You do not want to freeze it. But if it is frozen, it will thaw, and then it can be used. But when frozen, it will not be usable. I'm now going to go on to the BSACI action plans. You've got action plans for those who require antihistamines only, for those who require adrenaline. And you have got them currently for EpiPen as well as Jext. Neffy, we're hoping that in due course there will be one available very soon. With an allergy action plan, this is the antihistamine. The first one on the screen is the antihistamine only. And with all of them, you will know what the person is allergic to, their name, date of birth, what to do in case of a mild reaction, what to do if you notice signs of anaphylaxis. So for the antihistamine only, recommendation would be call 999. And if you have been prescribed adrenaline, it goes through how to use it and position. This, for example, is the one for Jext. So you have the diagram showing you how to administer the Jext, whereas in the previous slide, you have the diagram showing you how to administer the EpiPen. Now, most UK clinics use the allergy action plans provided by BSACI. However, some may choose to do their own, and for example, schools may also formulate their own action plans. It's very, very important to update these action plans annually at each appointment or at any point of change. So for example, perhaps a new allergy has been discovered or one has been outgrown. You would need to update this. Make sure that your contact details are up to date. Make sure that these plans are shared with the appropriate people. For example, if you've got a child, then it would be, with the nursery or the school, with other healthcare providers. Weight is very important as well. Once your child, for example, reaches 25 kilos, then you would need to get up to the adult dose. So you would need to monitor that as well. And as I mentioned, the Neffy plan isn't available as yet, but this will be in due course. Touching quickly on spare pens in schools. In 2017, UK legislation was introduced, allowing schools to purchase adrenaline without a prescription for emergency use, as long as a headed letter was taken by the school. It is voluntary, so schools are not expected to purchase these spare devices. And in addition, it's not a replacement for a child's own medications. So when can these spare devices be used? If your child has got an adrenaline device and at that time it is either found to be out of date or it is misfired, it's not available for whatever reason, that is when the spare device can be used. However, to use this device, in a pupil known to be at risk of anaphylaxis, where they've got the allergy action plan signed by a healthcare professional, and it also has consent from you so that the spare pen can be used, that's when it can be used. So what about if somebody has an allergic reaction at school, for example, and they have no known allergies as yet, or, they've just had a reaction, or it's a visitor? In that case, as long as the school calls 999 and the 999 call handler authorizes them to use their spare device, then it can be used. This is, again, a screenshot of an action plan, and you can see right down at the bottom is the parental consent area, which must be signed. Now, as I said, most children's clinics in the UK do issue the BSACI plans to their patients, but alternatives are being used as well, but they must include known allergens, whether adrenaline has been prescribed, what the type is it EpiPen, is it Jext, is it Neffy, and what dose it is. Parental consent, as we mentioned, and optional is a photograph of the pupil, just to allow for a visual check to be made. As parents and guardians, there are certain responsibilities, and the responsibility is to provide the medication and up-to-date information about your child's medical needs. We also need to provide the school with an allergy management plan, again up-to-date, signed by a healthcare professional, which includes parental consent for the treatment of an allergic reaction and use of spare AAIs if the school holds them. And also, we need to provide appropriate medications, check that they're in date. Schools do check, but it's also our responsibility to check and replace as quickly if needed. I'm now going to go into living with severe allergy and provide you with a few practical tips that you may find useful. Obviously, know your allergens. Communicate and educate. So communicate with your school, with grandparents, with friends, with other carers, what your child's allergies are, how to recognize the symptoms, and how to treat, and the importance of not being frightened to treat. They're not going to do any harm if they treat when not needed. Avoidance strategies. Think about labels. These can change, so it's often a good idea to go and check labels to make sure there are no changes. Allergy UK, for example, have got allergy alerts. And if you've signed up to those, then they are informed by the Food Standards Agency. So if foods are withdrawn, for example, or they're recalled, or there's mislabeling or cross-contamination, then as long as you have asked for this, then alerts will be sent to you either on social media or email. When you are eating out, please do not be afraid to ask. Say what you're allergic to. Ask what the allergens are. If you feel that the information being given to you, you're not comfortable with it, you're not confident, then don't take the risk. Plan ahead and seek support. I would say at every appointment, you must be trained with regards to how to use your devices. Have a refresher. You could also reduce anxiety in children and young people. It's very important to let them know that adrenaline is very safe. Make them familiar with their medications. For younger children, obviously, they may not be able to use the devices, but just show it to them. Say, this is your EpiPen, or this is your Jext, and, show them videos, or just have a play and show them how to use it, where to use it. In clinic, often when I'm training with the younger ones, I say, well, this is the EpiPen. I'm going to show how to use it. Can you help me count? And when I press it into my leg, I let them count. It's about getting them involved slowly. Show them videos. Practice using a trainer. For young people, or those at secondary school, think about friendships. If they're out and about quite a bit, or they hang out with a particular group of friends or a friend, then, it may be an idea, as long as they're comfortable, to get the friend to know what signs of anaphylaxis are, what the available medications are, where they are kept, And if, they are not comfortable with using the adrenaline, then perhaps, just as long as they call 999 and get help in position. Finally, we're coming up to the Christmas holidays, and quite a few of us may be traveling either within the UK or abroad. You will want to think about your adrenaline. Is it in date? Just have a look. The temperature, think about where you're going, how you're going to transport it. If you are going to be flying, please make sure that your emergency medications are kept in your hand luggage. You can get, along with your allergy action plan, you can get a travel certificate as well, signed by your healthcare professional. Have these to hand with you. Have emergency numbers for the destination that you are going to, and use a translation sheet if you will find it helpful. Thank you. This brings me to the end of my presentation, and thank you for your time.
In the next part of this webinar, I would like to share with you an educational video that was aired by the peak professional body for allergy in Europe, EARCI. And this was a video that was launched last month as part of an Anaphylaxis Awareness Day campaign. It shares lots of different perspectives on anaphylaxis and experiences of people that have walked that journey. So we would like to play this video now.
Sometimes danger hides in plain sight. An ordinary meal, a birthday party, a child's laughter. And then, in a heartbeat, everything changes. Anaphylaxis doesn't wait for awareness. It exposes the blind spots that can cost a life.
My daughter Natasha, we discovered she had food allergies from when she was very, very young. When she was 6 months old, we were on holiday and I gave her a tiny bit of banana. I literally just smeared it on her lip and she didn't like it and she was trying to sort of spit it out with her tongue. And within 5 minutes, her face had swelled, her mouth had swelled, she was bright red all over and she had an anaphylactic reaction.
Well, anaphylaxis in simple terms is explained as the most dramatic, the biggest and the most terrifying allergic reaction you can experience. It can start in a few moments and it can go to a level that is enough to kill a person.
For 9 years, she hadn't had an anaphylactic reaction. She was managing it well, and we were generally as a family. But on the day she died, she had eaten a baguette sandwich that contained sesame seeds, and they weren't visible to the naked eye, and they weren't mentioned on the food label. She was boarding a plane, and when the reaction started, she just really needed medical help that just wasn't available to her. And even though she was injected with adrenaline, it made no difference, and she passed away later that day in a hospital in Nice.
I think I should define that with a severe reaction, immediate reaction, after a trigger. With more words, it is a reaction that happened to a patient when he take food, a drug, when they have an hymenoptera, a sting, and immediately the patient start to have some symptoms.
The reactions involve urticaria on the skin, that means wheals on the skin, and reddening and pruritus. It also involves nausea and abdominal pain and circulatory problems or respiratory problems with dyspnea. It becomes difficult if you don't know exactly the trigger. The trigger normally is of a drug, of a food, or an insect venom. And if you don't know the trigger, you have got a lot of work to do.
So I was on holiday in Italy with my friends. We were out in the evening, had dinner, and then after dinner, where I was eating obviously gluten, walked to a bar, and there when we arrived there, I started feeling the symptoms, which I didn't know what it was at the time. And then I lost my eyesight. I couldn't see anything and I couldn't hear anything.
¿Cuáles fueron los síntomas? Pues uno de los síntomas que tuve como diarrea, malestar en el estómago, me empezó a picar un poco las axilas, la palma de las manos, y yo comprendí que mi cuerpo ya me había cambiado.
When the unknown becomes known, fear turns into knowledge and knowledge into survival. Each story begins in darkness, but it's only by seeing the blind spots that we find the spark of light. For centuries, the mystery of sudden allergic reactions has challenged doctors, patients, and science itself. What begins as a simple rash can become a race against time. To understand anaphylaxis is to confront how fragile and extraordinary the human body truly is.
Anaphylaxis actually was researched by Portier and Richer, and they received the Nobel Prize for it in 1913. It was at the time when it was thought that the immune system was only positive for the body. And they did their research, interestingly, on the yacht, the personal boat of the Duke of Monaco, on the immune system fighting toxins from jellyfish. And they were using dogs, and they were first training the immune system with very few minute amounts of the allergen, and then increasing the dosages, thinking they would get protection. But they saw that the animals reacted differently. They had a severe anaphylactic shock. And this they described. And they termed it anaphylaxis. This comes from the Greek, and it says ana, which is the opposite, against. Phylaxis is protection. So anaphylaxis means against protection.
During anaphylaxis, the main mechanism depends on the vessels. The vessels get widened and there's the leakage of fluid from the vessels. So the main drug should be adrenaline, which is known as a drug to tighten the vessels.
The sooner the adrenaline is administered, the best result for the patient. We cannot wait and try to decide whether this is an anaphylaxis, whether not. Let's wait, because the sooner it is administered, the better. The health system needs to understand that anaphylaxis can happen at any age, that it is can be a quite severe reaction, that the patient can die, and that they need to give the tools for diagnosis and for treatment, and that the auto-injector needs to be available worldwide, probably in the future, then intranasal adrenaline.
One of the challenges we face with how we understand anaphylaxis is that we really do not understand the immune pathophysiological mechanisms of anaphylaxis, because this will make it much easier for us to develop novel therapeutics, prevent the onset of severe reaction that one we see in our patients. Well, research is fundamental to support patient management, because the research we do is then translated from what our physician colleagues are able to see patients and really then treat them. But what's really important is how we get there, and what we need is have substantial funding work which can support all the research that we do, immunological research, translational research, but also something that really helps move from bench to bedside, because what we need to do is we need to start at the bench, we need to do some very fundamental studies, and then we move into patients, and where we can really focus on curing or managing our patients better with better treatments, apart from just having adrenaline that we have currently today.
Of course, we need more research, because we know that adrenaline is effective in approximately 5 minutes, but we need a drug that can act faster. Also, we need research on the mechanism of anaphylaxis so that we can prevent the attacks and the patients can be free of anaphylaxis attacks, because we know that in some patients anaphylaxis can occur without an exposure, and we call it idiopathic, which means the attacks can occur spontaneously.
As a medical doctor, many times parents who have their children that never experience an anaphylactic reaction, they ask me, should I carry an adrenaline with me because I never had a reaction, but I may have in the future. And they are right, there is a risk factor. Although we are always focused on reassuring and promoting health and giving confidence, so we don't want to people to be overstressed with disease. We need to find better risk factors for the ones that we will experience in an episode.
I think I would like to change that I should have taken it more seriously when I had my first attacks or triggers. Instead of being the naive person I was, I should have gone to the doctor sooner to start the investigation.
Knowledge doesn't end the fear, but it teaches us its language. The more we uncover, the more we realize how much still lies beyond explanation, waiting for us to listen, to study, to care. Imagine living every day with eyes wide open, scanning every label, every bite, every breath, every act. For those at risk of anaphylaxis, vigilance is not paranoia, it's survival. This is life on constant alert, where awareness becomes both shield and burden.
We were on holiday. We were here in Stockholm in a restaurant, and I remember I'm always trying to talk to the chef who's making the food to shorten the chain so there will be no mistakes. And I was explaining all the allergies, and he said, "Oh, no problem, no problem." And due to this, I trusted him because the way he described how he was going to prepare the food, I felt safe. So the food came in, and I asked again, "Is everything?" He said, yeah, don't worry." And my son had 2 bites of the meatball, and I immediately saw that something changed. He just stood up, very disorientated, and ran to the bathroom. And we had like a medicine bag with us, but at that time we didn't have any adrenaline. So I ran after him into the bathroom, and he didn't know if he was going to throw up or was he was just feeling very, very confused. And I also knew then back in my head that our doctor has said when he's having a reaction, try to be calm, otherwise he will be stressed and that can then increase the reaction. So I thought, okay, I have to be calm, he needs to go to hospital. So we gave all the medication that we had at that point. Then we put him in his little sister's trolley and ran to the boat because we are on an island. And of course I know I did everything wrong. I should have called the ambulance, but in my mind I thought I was doing the right thing. And I think someone was watching over us that day, because when we were on the boat, I called my father, who met us at the boat, and he drove quickly to hospital. But in the end of the trip to the hospital, I had to shake my son because his eyes had started to roll, and I was really, really terrified what would happen.
So it is, especially with kids, it's extremely important that the kids need to understand. Then the parents and many people in the family need to be ready for administering the adrenaline and to identify the food. Usually they also need to understand how, because it's affects the family life. They need to, because if they are cooking, they need to prepare the food. For example, here in Spain, that during Christmas, all the family sit together, and we all, if it is cold, everything is closed, and we eat shrimps. They need to understand that even with the cooking of the shrimps, it's enough for patients to develop reactions. So everybody needs to understand, because if not, sometimes the answer is, there is no problem, it's only a small piece. Grandparents are extremely important because they need to understand that it is a severe reaction. So everybody in the family needs to be involved and ready to act and ready to prevent the possible reactions.
I think you're on mute.
I hope you enjoyed that educational video. If you do want to watch the full version, then have a look on the earkey.org website, where you'll be able to watch it in full length. I'm delighted to be joined now by our expert panel who have co-chaired the previous two sessions. We have Professor George with us and nurse specialist Alia. Welcome. You won't be surprised to know that we have had lots of questions as a result of your engaging presentations. I think I'd just like to make it clear to those listening that we're not able to answer all of the questions in the interest of time, and that some of the questions have been asked in a very specific nature to the individual, which would be giving specific medical advice. So the questions we do answer will be of a more generic form, and if they're specifically related to work we do at Allergy UK, then I will answer those offline at a later time. So without any further delay, I'm going to jump right in and ask my first question to yourself, George. So we've had quite a few questions in around the timing and onset of symptoms, and lots asking a similar question around the theme of, do anaphylactic symptoms always come on in a short time frame? So are they always seen within a few minutes, really, of exposure to the trigger allergen?
Yeah, so thanks for the question. So anaphylaxis can vary enormously, but for most allergic reactions, they will happen quite soon after the exposure, particularly if it's a food, for example. So a child will eat the food. Soon thereafter, they'll generally dislike the food and start developing some adverse symptoms. It can be subtle and it can be more obvious, but certainly within an hour, you would have expected the allergy to come on. Things can alter that, depends how much they eat. Is it fresh milk as opposed to baked milk? Is it hidden in a matrix of cooking? So there are lots of variables to that, but generally you will figure out within a short space of time that there are allergic symptoms coming on.
That's great, thanks, George. My second question, I'm going to pass to Alia, and I'd love for you to offer a couple of top tips or advice on children that are transitioning from primary school to secondary school. There's quite a lot of interest in how to support those children. You covered it briefly in your presentation, but could you offer just maybe a couple of tips?
Yeah, sure. So in clinic, what's the most common tip that I would do is, as soon as they're in year 5, obviously in primary school, they're not expected to carry their adrenaline devices, emergency medications, but from as young as possible as you can, try and get them used to what's in their medication kit, what it is used for, what they're called. And then definitely once they hit year 6, I would definitely want to see them using the practice devices, knowing what the ambulance number is. And believe me, most people will say 911 instead of 999. So just simple things like that you could start with. And then as they transition and, they start spending more time with their friends, I always say that you may not want to tell all your friends about your allergies and your emergency medications, but the ones that you are particularly close to, show them where they're kept, what they need to look out for, and when they need to call for help. Simple things like what position that the person should be in, things like that can make a big difference.
Thank you. I think they're really useful tips, and you're right. A lot of adolescents, they're quite reserved and they don't necessarily want to tell everyone. So just having those few key good friends or good peers that they kind of give a bit more detail to, I think is really valid. George, the next question is about medication, and somebody's particularly interested in whether they should take a liquid antihistamine or a tablet if they're having an allergic reaction. And in this instance, we'd be talking about a mild to moderate allergic reaction.
Yeah. So antihistamines can certainly help to keep a child comfortable when there's some hives and some slight discomfort. Younger babies obviously have to take a liquid, but as they get older, when there's a choice between a tablet and a liquid, then the family need to decide. The problem with the liquid is the volume becomes quite big. So if you get up to 10 milligrams per mil, that's a full 10 mils. You'll have to carry a bottle. There's problems with that at airports because it's a lot of liquid. It gets picked up in scans, which of course you can get around, but it's very stressful. Once you've swallowed either a liquid or a tablet, it'll go into the acid in your stomach where there's a lot of liquid and it'll get eaten up, and it makes very little difference. So I'd certainly teach people tablets are a lot easier. You can carry them, in wallets and purses and backpacks and whatever you need. Whereas liquid antihistamine is a lot bigger, will often come in glass containers unless you decant it. So that's a bit more of a problem. But physiologically, it won't make a difference to your body whether you use one or t'other. Some children can swallow tablets very early on and others can't. The classic trick is if they battle to swallow a tablet, is to actually let them put the tablet in their mouth and put their head down and swallow. And it seems counterintuitive because you want to put your head back to swallow. But if you put your head down, you could try this tonight if you're having a multivitamin. It's much easier to swallow that way, and children learn very quickly if you support them through that.
That's great. Thank you for sharing those practical tips and the practice for taking the tablets. My next question is, I'm not directing this to anybody specifically, so feel free to jump in if you'd like to answer it. Can you clarify in which instances do you need to give a second dose of adrenaline?
So you would give a second dose of adrenaline if, after giving the first dose, your respiratory symptoms, signs of anaphylaxis, either have not got better or they have started. So if they haven't got better or if they return, then after 5 minutes, you would give the second EpiPen or your adrenaline device. Also, as long as if the emergency crews haven't arrived, then you would use the second one after 5 minutes if symptoms are not any better.
Excellent.
It's quite rare. It's quite rare you need a second. It's probably about 10% of cases, so it's not entirely uncommon. And even today we experienced that. So it's symptoms that are just ongoing. The body can certainly tolerate the adrenaline very easily. So you'll worry that you're going to overdose your child, but if it was scripted to you and it's weight and age appropriate, it'll be quite safe to give.
Great. Now, there's quite a few questions coming on. I think this is nuanced on explanations and the way people have interpreted the advice that you've both given your separate presentations. But just to clarify for those that are listening, it was regarding timings of medications. And I think the key message here is that we don't want to delay giving adrenaline if there's signs and symptoms of anaphylaxis, but there is a role for antihistamines and inhalers afterwards. And there was questions around there. I think George said there was no value in using them initially. And then earlier you talked about them being secondary medications. So just to make it clear to people, we weren't giving conflicting advice or different advice. We're all on the same page with our messaging. It's just a little bit nuanced. Do you have anything to add to that?
I'd say if symptoms are mild, use an antihistamine. If symptoms are moderate or severe, you must use adrenaline. Don't play for time giving an oral steroid or giving a salbutamol inhaler, because people do that because they really want to stay away from the injectable device. It's for all the reasons we discussed in our presentation. It's very stressful to give. The kids don't want it, and parents don't always want to administer it. But adrenaline is the only drug of choice in anaphylaxis. The rest is just and that's why it's been taken out of the guidelines, the antihistamine and the steroids. So when people are faced, we're now trained as doctors and nurses, we train to give adrenaline for anaphylaxis. Now, of course, there are variances on that. The child that gets a little mild cough, and people may want to use salbutamol, and we probably are in error. We do that sometimes in a medical setting because it's so safe and controlled. But the way we want to teach the treatment of anaphylaxis is there's only one drug, and that is adrenaline. Antihistamines are not going to stop anaphylaxis. They're going to make you feel a little bit more comfortable. If it's a first generation Piriton, which is still very common, it's going to make some children look groggy. In an acute setting, that's going to be even more frightening. So troubling symptoms of a moderate to severe nature, don't faff around with other drugs. Get going with your adrenaline. Now, people sometimes want to give a steroid if they know the patient has asthma and they've had adrenaline and they want to stop biphasic reactions or late onset asthma. Steroids haven't been shown to reduce biphasic. Biphasic reactions are secondary reactions that can occur 2, 3, or 4 hours after the first reaction. They can perhaps stop asthma, so they're not, entirely out of any guidelines, but don't be giving steroids in the acute setting. They take hours to work.
And as well, if the person has asthma as well as an allergic reaction, and they've had their adrenaline and they're wheezy as one of their symptoms, would we then recommend using their inhaler?
If it's new onset wheeze, respiratory symptoms, it's anaphylaxis, and only two things can happen. That can spontaneously get better, or it can get worse unless you treat it. And you don't want to stick around. It's a serious matter. You don't want to stick around to see it's getting worse. So rather just treat it early on. And in fact, we do still use adrenaline for the treatment of asthma when kids are very fractious and they won't tolerate a nebulizer. Subcutaneous adrenaline was standard practice and is still in some guidelines. Parents obviously aren't going to do that, but it will help. It'll help with the anaphylaxis and it'll help stop the acute onset wheezing.
So absolutely. So if there is anaphylaxis, then you would absolutely go straight away. Do not wait. Go for the adrenaline. Call 999 because it's really important to get the help, make sure it's on its way. And then while you're waiting, as George said, that the other secondary medications aren't going to be effective immediately. So yes, the main point is get the adrenaline in, even if you think that if you're not going to get it, you're not going to do any harm.
One of the ways adrenaline works, as I said in the presentation, is on the beta-2 receptor, and it stabilizes the mast cells and basophils, these cells that are full of chemicals that are released during anaphylaxis. And so the earlier you give it, hopefully you would also have immune modification. That whole response would be immune modified, because all the other effects of adrenaline are just like a petrol. They're just driving your heart faster, stronger, quicker, opening up your airways. But you also want to modulate the immune response. And certainly that's our hope, with newer devices that are coming onto the market, that if people use it earlier, perhaps, this is not proven, but perhaps it will help moderate responses.
Yeah, and I think if people are worried and in doubt, then you provided the reassurance that adrenaline is a safe medication. It is in fact a synthetic form of a hormone that we produce within our bodies for the fight and flight response.
Yeah.
A lot of questions as well around signs and symptoms and what relates to anaphylaxis, what kind of relates to a mild to moderate symptom. And I'm going to track back to Alia's presentation showcasing action plans. For me, these are a really great written information tool and something to refer back to, because they clearly state on them the symptoms of mild to moderate allergic reactions and those that we should be wary of with regards to anaphylaxis, so your ABC, airway, breathing, and your conscious level. And I think it's really important that people revisit these from time to time, because you can be really smart if you've had training, you may have had a recent interaction with an allergy clinic, but you do forget these things over time. So go back, have a look at your action plan, check it's up to date, revise the content on it, because it is a really useful tool. So I have a question here about EpiPens that are out of date, or AEIs in general that are out of date. Is an out of date adrenaline auto-injector better than no auto-injector, should you need to use it?
I would say yes. Just make sure, for example, with the EpiPen, you've got the clear window. You would look at it, make sure there are no particles in there. As long as it's clear, that's fine. It's better to use it than not use it, if that's all you've got.
Correct. Adrenaline, the drug itself is very stable. It's just the mechanized sort of ejector device that can perish. Because when there was a great shortage of auto-injectors, the companies did say there's at least 3 extra months worth beyond that date. But as a general principle, obviously don't try and go beyond that. And so most schools won't allow your child to hold out-of-date medicine.
And I think that's a great thing now about these expiry alert services, about the education that Alia and I do to patients in clinic. We do say to people, you've got holidays coming up, be on top of it. It can take a while, can't it, to get a prescription renewed, to get to the pharmacy, to, so do allow yourself time, and hopefully you won't be in the position where your AI is out of date. But there is occasions where there's supply issues up and down the country, and they're the instances really that I think people are relating to when they're told, should we? And they have those kind of moral dilemmas. Okay, the next question I have is about being hospitalised due to anaphylaxis. So if a person has had a severe allergic reaction and had a hospital admission, what is the likelihood that they'll be in hospital again with a reaction?
So if the question refers to if you've had a severe reaction, will you always have a severe reaction?
I think that's the essence of the question, George, yeah.
So it's highly variable. There's a chance it may be more severe, but there's an equal chance the next time it may be just as milder than what you've just experienced. Because of all those variables, again, how much you eat, what is the matrix, how are you on the day, is your asthma active, have you had ibuprofen, are you jet lagged, have you had an exciting, end of year day like all the kids are having? All these things moderate your immune response. And so it's variable. But the biggest variability is how much you eat. So some allergens are hidden in the food. Wheat, for example, is baked into a matrix. So it takes your immune system a little while to figure out that you've eaten wheat. And those reactions can sometimes be a little bit delayed and often are respiratory and can be troubling. Whereas something like a peanut, peanut butter, your mouth very early on tells immune system alarm goes off, and the kids hate it. They dislike it. They don't finish the meal. And so hopefully they stop eating a larger quantity of it. But past performance doesn't predict future performance. The biggest risk factor is age. As you get older and older, reaction severity can go up.
That's great. The next question I have is around travel and allergy. And I'll direct this one to yourself, Ali, because I'm sure you get asked this in clinic a lot. But I have the question posed is child with a severe allergy, family apprehensive, not understanding about travel overseas and how they can overcome this and feel more confident. And what kind of conversations would you have or tips would you offer?
So one of the things most commonly asked is, what do we do on an aeroplane? And my tip is that the best thing you can do is probably give the armrest and the food table a wipe down, and make sure you've got your medications with you. If you are going away, research beforehand the restaurants that you might be going to. You could also get some translation cards, make sure you know the emergency number for the place that you are traveling to. Yes, any other tips, George, that you would say?
If you're food allergic, plan your meals. What are you going to eat in the terminal? What are you going to eat in the airplane? Kids get angry and hungry frequently, so you've got to be. But that becomes very hard if you're doing a double long journey to New Zealand, Australia, or something. So it's hard for families to stock up with food that covers an entire journey.
Yeah. And some airlines, airline policies vary wildly. Some airlines manage allergy very well. I'd say do your research before you plan or book your holiday. Look into where you're going, look into what airlines fly, look at their policies. Medical assistance is really valuable for children and families travelling with allergies. They can often waive things like excess baggage if you do need to travel with, for example, tins of specialist baby food formulas. If you need to take extra equipment like specific foods in bigger quantities. And as well, communication, like at every step of travel, I think is really key from the minute you book your holiday to when you're about to board, before being offered any food or snack, because staff change on flights and things. So yeah, communication for me is really important, and as well having some way of communicating with the country you're going to. So carrying things like translation cards, so having the allergies that you have, specifically if it's to certain foods, written in the format of the country you're going to in a language that they're going to understand. So I think all of those things can help people feel more confident to take that step. And once you've done it once, it's a learning journey, but I do feel like people gain so much from traveling, and it increases their
No,
confidence.
yeah, that's terrible when their allergies get in the way of normal travel. People worry a lot about casual and aerosolized exposure, and the risk is actually very low. The greatest risk is from eating your allergen, or of course if you were to smear it, in your face, which is very unlikely. So the communication should extend to those just around you, particularly if you've got a young playful child. Sometimes people be eating food and try and feed or play with another child. That's far more important than what somebody's eating 10 rows away. And so often the announcements, people get very stressed around that if they're made or not made, and they're usually only made for peanut and not tree nuts and milk and egg and wheat. So the whole thing's a very stressful mess for our families, and not always increasing safety. And I try and reassure all the families that I see that we skin prick test them routinely, and we've been doing this. Many of them have had 5-10 sessions of skin prick testing where the allergens pricked lightly into their skin, and they've been quite safe through that process. So just try and re-empower them that obviously be cautious. If it's an aerosolized allergen, like very concentrated milk or very strong fish aroma, then a lot of women and mothers will travel with a scarf or whatever, and people wear COVID masks, so you can put that over your child. And modern aeroplanes rapidly clear this allergen. The biggest risk is eating it. And so you have to plan around the meals. And as you were just saying, it's a real mess, different airlines telling you different things. And on a second leg, even if they'll tell you what, flying to Singapore, what they'll serve, you're not always sure what they'll do on the next leg. So it's very hard for families to plan ahead.
I would also say perhaps take some spare snacks or, food with you just in case. That can often be helpful. And when you're away, if you are going to communicate your needs to the restaurant, for example, if you're not feeling confident about the responses, that's when I'd say don't take the risk.
Yeah, I'd agree with you. The next question is about symptoms and the continuation of symptoms after an episode of anaphylaxis. And this person would like to know, is it normal for digestive symptoms to continue days after having anaphylaxis?
So severe anaphylaxis is a huge immune jolt. So the skin will often be troubled for days. The respiratory symptoms, by definition, should settle, and the cardiovascular symptoms should settle. But your gut can be upset. It's some people have acute diarrhea within an hour or 2 or 3 after having an anaphylactic event. And the medicines themselves can upset you a bit. If somebody's giving you oral steroids, certainly the adrenaline dose. And you also get, it's kind of a post-traumatic shock syndrome. It's to both family and child, because it's a life-threatening event. It's like a car just missing your child, with hooters blaring. It's a terrifying event. And so I always tell families just to be careful, be easy on themselves. Be aware that there may be some emotional fallout in the few days afterwards. That's actually very common and under-recognized.
Yeah, thank you. That's a really helpful response to that question. The next question I have is around Anaphy and the intranasal device and accessibility. A lot of people interested in the idea of maybe trying an alternative. But just wondering how easy it is to get their hands on it via the NHS. And I guess that's going to vary from region to region and health ICBs and different trusts. Is it starting to trickle through in the NHS and private practice as well?
So within our NHS practice at the Evelina, it's not totally through the ICB and scriptable just yet, but it's in process. So this medicine's only recently been licensed and available in the NHS. So it will trickle through, but it'll take some months. And it'll take months for GPs to be aware of it, to know to script it, for nurses to be able to train you and to be skilled up, and schools. And so there's a whole package that needs to go with it. It's not just the device on its own, but it will happen, and it is happening. And the NHS will support it because it's got a longer expiratory shelf life. It is more temperature stable. So over time, it's likely to work out more cost effective. So it'll save society money, but it also is also a very good device for patients. So it will come out. It is available in private practice. We've been issuing it for some weeks now, and it's just been an interesting lesson because you want to do this as shared decision making with parent, eligible child and healthcare practitioners and just asking them which device they would prefer to carry in. Certainly our experience has been that the older kids are all very keen, if they can access it, to try the device out, to try carrying it.
Yeah, and there's a few questions here about whether it's available in Northern Ireland and things, and I'd perhaps direct people to the Your Nephew website. There's lots of information on it, and they will have a section there for patients, for members of the public, and they'll probably have a section on frequently asked questions. So if you do have a medicine specific question, then head over and have a look if it is on their website. So my next question is there a number or is there a limit to the number of adrenaline injections you can give whilst waiting for emergency services?
Well, hopefully, somebody should be with you within like 5 minutes, 8 minutes max, I think, but that is why we would say just be prepared. So, if in a normal setting, if you need, in a hospital setting, if you need a second adrenaline device, that's when we would ask for extra help to support us. So, yeah.
That's right. And very, very severe kids, this is exceptionally rare, would go into an adrenaline infusion with continuous adrenaline. So you're better off doing it if it's indicated, and you do it at set time intervals if there's no additional medical help to hand, as Alia says.
And I think the key thing is calling the ambulance as soon as possible, isn't it? Being really clear that it is anaphylaxis, because then the call handler is going to triage that as a category 1. And within the ambulance service, they have, targets, and they have priority systems. And anaphylaxis is up there, isn't it, guys, with some of the most severe kind of medical emergencies there are. So they will get an ambulance to you. And having had to call an ambulance for my son who has anaphylaxis and living semi-remote, the ambulances will come to you as fast and as quickly as they possibly can. And then they're going to have the help. But that is why we make these recommendations that people carry to adrenaline devices.
Absolutely. So what you said, it's very important to state anaphylaxis, because often when I'm training, the response I would get is we would call 999 and say that we've had an allergic reaction. But that could be a mild to moderate reaction, so you need to be really precise. And if you are making that call and you forget the word anaphylaxis, if it's a young person, for example, what I say is just tell them I've had an allergic reaction and I've needed to use my adrenaline device. And that should indicate to them that it's serious and somebody needs to get to you immediately.
Yeah, I think they're all really valid points, and just practice saying anaphylaxis. It rolls off of our tongues because we say it so often, but actually if you break it down, like you mentioned earlier on, George, to anaphylaxis and practice saying it, then it is easier to say. Okay, so I have another question here about a review for allergy medications. So it's an adult who has had anaphylaxis in the past, and they carry 2 adrenaline auto injectors. They haven't had an allergy follow-up since being a child. It doesn't say how old they are now into their adult years. Should I ask my GP for a review is the question.
I think you've got a right to a review. You're living with potentially a disease that potentially can cause an acute severe scenario. You're carrying these life-saving medications. I think it's only right that you get assessed once in a while. We all can grow into allergies and grow out of allergies. It's exceptionally rare as an adult if it's a seed, a peanut or a cashew or sesame. The milks and eggs, obviously, most people will outgrow when they're younger. So you do need a fair amount of follow-up in young children, and as you get older, that space can extend a little bit if you don't have troublesome asthma, eczema, hay fever with it. And then in adulthood, it depends how often adults want to be seen, but it's a potentially severe illness, and so you can become unwell. You want to be seen. Things change. I mean, we've got There are new drugs on the horizon, the omalizumab, the Xolair. They're not licensed for food allergy yet, but they certainly are licensed, these biologics, for other allergic conditions, eczema, asthma, hay fever. We've got the option of Unefi now that older patients over 30 kilograms can use. So it's an exciting time.
Yeah, I'd agree. And now more than ever, we are in a position where we can give patients a lot more personalised treatment and care. And there's a lot more choice, isn't there, open to people. And sometimes that comes down to locality and where people live. But as well, there's lots of great resources online to help people self-manage their allergies. So we have a lot of great resources on the Allergy UK website with regards to patient information leaflets, with regards to specific sections. We run healthcare professional events to try and upskill and educate HCPs. And we do webinars and podcasts. So there is so much information out there that is really great quality. I know yourself, George, you do a lot of work on social media. And I think that's wonderful because we're helping to educate, we're helping to provide some really good messages around looking after yourself, living with allergies. So I think that concludes our question and answer session. A big thank you to you both for your time this evening. I'm sure you have enjoyed this Q&A session. And I'd like to say a big thank you as well to everybody that's listened. We had a huge amount of people sign up to listen. If you weren't able to make it, you can catch up with these sessions on demand afterwards. They will be on the resource section of the Allergy UK website. We would also ask a small favour, if you have enjoyed this presentation, if you would like more events like this, we'd love to shape your experience and learn some feedback from you. So if you could jump on and do a quick survey from the QR code above, that would be absolutely amazing. And last but not least, a big thank you to our sponsor.
Thank you.
Thank you.
Thank you all for joining us. Should you wish to engage with Allergy UK, we would love to hear from you, and our website address is allergyuk.org. Thank you very much for listening, and I wish you a pleasant evening.